So you've had an extensive amount of information given. You practiced pain assessment last semester in Skills Lab. Pain assessment is a big issue with every patient in the hospital, if they have chronic pain, if it's post-surgery. So, what kind of questions would you ask a patient on a pain assessment? Well, some of them are pretty obvious, such as the location of the pain. How would you describe the pain? Um, what type of pain do you have? Patients will use certain words that they're gonna be familiar to them. Um, it's a stabbing pain, it's a burning pain, it's a pinching pain, it's pain all over. Uh, Pain hurts right here. I've heard that from patients. Where does it hurt? Well, right here. Well, where is right here? You need to describe the pain. Impact on ADLs. Because of your pain, what can you do or not do? And then, of course, pain scales, 0 to 10, 0 to 5, the charts for children, the faces, um, a thermometer kind of thing, pain, the worst you can imagine. I like to use the comment for a mother. Pain is the worst you can imagine. It's like giving birth. Sometimes that helps. The pattern of pain, is it continuous? Is it intermittent? Where's the pain? Um, does it radiate? Is it in one place? Does it come and go? The onset, when did the pain start? How long does it last when you have the pain? What makes it worse? What makes it better? Um, Also, while patients are in the hospital, you need to ask the patients their pain goal. If someone just came out of surgery and they've opened up their gut, they're going to have pain. So to say my pain goal is zero pain, well, that's not going to be a logical pain goal. You will not have zero pain because you just had surgery. So maybe a pain goal would be 3 out of 10, maybe 4 out of 10, maybe 2 out of 10. The other thing you have to realize is someone's 2 is someone else's 9. Um, Someone's 10 might be someone else's 5. So everybody has a different way to categorize their pain. If someone's in chronic pain or they've had a lot of pain, they know what works. Tell me what you've done in the past to relieve the pain. What do you do when you have the pain? Do you lie down? Do you take a Tylenol? Do you take an opioid? Which ones work? Uh, Also, when a patient comes in, what kind of pain meds have you had in the last 24 hours? These are all types of assessment that need to be done. The more you have, the better you'll be able to manage the pain. Doctors also will ask similar questions. So everybody knows the universal pain assessment. This is what it looks like: the happy face, a very sad face, the different colors. Um, this is in all kinds of languages. Here's another one that you can use, basically um, distress from colors as well. Faces works well for little kids, happy and sad. Here's a picture of dermatomes. A dermatome basically is the nerves that come all off of the spinal cord. They innervate certain areas of the body. So if a patient is having certain pain that you know because of a compression in the spine or something like that, then you know what area of the body that pain is going to come from the nerve. If a patient has a local block for surgery, they know exactly what area to do the block, and it's going to deaden the pain in the area using the dermatomes. They know where exactly the pain will be received. So drug administration. Everybody knows oral medications, IV, epidural, intrathecal, PCA. What other kinds are there? Think about that. Um, Some other ones, sublingual, nerve block. So the World Health Organization has this step pain management tool. Mild pain, moderate pain, and severe pain. Notice that mild pain should be able to be managed by aspirin, acetaminophen, NSAIDs, and adjuvants, different kinds of other medications other than pain meds. So adjuvants sometimes are muscle relaxers, antidepressants, anti-seizure medications. Moderate pain, notice they've added some opioids, oxycodone, hydrocodone, codeine. You don't see codeine given that much anymore, at least in this country, probably other countries. There might be more common, as well as adjuvants. Severe pain, step three. This is where you're getting into the straight morphine, methadone, fentanyl, oxycodone. Fentanyl is a very fast-acting pain given IV or a fentanyl patch. Methadone is what patients that go through the cure for heroin, they will take methadone every day. Methadone, though, is also a pain medication. You'll see that on the floor with patients. Just because they're taking methadone doesn't mean they used to be a heroin addict. It is also a pain med. So combination at each step is where the patient should be and what we give the patient. A patient with mild pain does not need to receive morphine. Patient in severe or moderate pain, aspirin probably is not going to do the trick as well. So different combinations of pain control sometimes works the best. If you have patients post-surgery, the doctor will write perhaps more than one pain medication. So the patient, you pretty soon figure out that if you give the fentanyl first, and then if that's followed by oxycodone or a Vicodin, a Percocet, things of that nature, maybe the two working together is better than the one. Some forms of adjuvant therapy we've talked about, I just mentioned. So opioids, anti-inflammatories, neuropathic agents, for example, Neurontin, gabapentin, muscle relaxers, Flexeril, antidepressants, Paxil is a very common one, benzodiazepines, Ativan, Versed, anticholinergics. All of these have their place in pain management, especially for chronic pain patients. Nerve block, that's another form. Patient can receive nerve block. An intrathecal pump. Intrathecal pump usually is baclofen. The pump is under the skin. It lasts up to 90 days. It gives a slow dose to the area in the spinal cord. Patients love this. They just basically go in and refill the pump, and they always have a small dose of pain medication. A TENS unit is basically electrical stimulation of muscles in a certain area, and constant stimulation, a low electrical impulse can deaden and basically stop the movement of the pain through the nerves, and that helps. Other kind of things, heating pads, physical therapy, massage therapy, relaxation, meditation, all these things have their place for chronic pain, and some people use them all the time no matter what kind of pain they have. These are just common things that patients do. Physical dependence. These are terms that you're going to hear, and you need to know the difference of them. Physical dependence is basically patients that are going to go through a withdrawal. So this usually happens with abrupt cessation. That's why some pain meds need to be tapered off. A rapid dose reduction will do the same thing. So these patients actually have a physical dependence. They're addicted to well, they're not addicted, they just have a physical dependence. A tolerance. Patients that take pain meds over a long period of time, they need higher doses. So the doses must be increased to get the same amount of pain efficacy. Someone who is addicted to a pain medication and they are a true addict, those patients are the ones that will do anything to get the pain med or to get the substance. So they'll drive across town, they'll sell things out of their car, they'll steal things from people. I don't know why I just said steal things out of your car. It's like, hey, would you like my back seat? No, I don't mean that way. So they'll steal things, they'll sell things out of their house is what I meant to say. They will do anything to get that high. So those are the addicts that we're talking about. Physical dependence means you just can't come off the med. It needs to be tapered off, things like that. There is a form of pseudo-addiction that you sometimes see in the hospital where the patient watches the clock and they know the pain med's due every 4 hours. And at 3 hours and 58 minutes, they will hit the call light and say, I need my pain meds. Well, they're not addicted to their pain and they don't have a physical dependence. They just become psychologically attached to, I want that pain med. It's a good feeling. I'll feel good about myself. I like it. So I need the pain med now. And they become I need the pain med. This passes. It's just a common thing you see in hospitals. So opioids, the number one med for the step 2 and step 3 medication. Opioids have 3 things that they always are very common. They cause constipation, they cause sedation, they cause hypotension, and for a lot of people, nausea and vomiting. Now, out of all the side effects, such as nausea and vomiting, sedation, constipation, and even hypotension, respiratory depression, after taking opioids for a period of time, these will all go away. The body gets used to it. The nausea and vomiting usually goes away. The sedation goes away. Somebody who's on lots of opioids because of chronic pain or cancer patients, they can take high doses and they're not going to be nauseated. They won't be hypotensive. They won't be sedated. The one symptom, side effect that does not go away, doesn't matter how long you've been on the pain meds, is constipation. Opioids, that one never goes away. So there's a medication out there now called Alistor that for patients that are on chronic pain meds, they've been in the hospital a long time and they've taken opioids for a long time. This will actually block that constipation and get the bowels moving again. So that's kind of a cool med. It's given sub-Q, I believe. Other side effects for opioids, obviously urinary retention, common, especially if surgery was, that goes hand in hand with surgery if it's down in the pelvic area, respiration depression, and then withdrawal or physical dependence. Notice I say withdrawal and physical dependence, not addiction. If someone truly is taking pain meds for pain as prescribed, even cancer patients that take high doses, these patients will not become addicted. They may have a physical dependence, but they do not become addicted.